And the scary part about osteoporosis is actually more than half of fractures in the spine are silent. So patients could have it and not even know about it.
Hi, welcome to the Dr. Gill Show. My guest today is Dr. Kavi Devulapalli. Welcome to the show, Kavi.
Hey, Gil. Thank you. Appreciate the opportunity to be here.
Today, Kavi, we're going to be talking about back pain, and then we're going to go into the procedures that you can do as an interventional radiologist to treat some very painful back conditions and produce just amazing results with a minimally invasive procedure. Look forward to talking to you about that.
Should be good.
Now, Kavi, you are my third interventional radiologist on the show, and this is going to show the breadth and the diversity of the things that IRs can do. My first IR was Rafael Mariquin. He talked to us about strokes and how you can put little catheters up in the brain and take out clots and do all these amazing things to treat stroke. In episode 61, we had my friend Max Lazinger talk about all the things he can do in the body, just amazing stuff. And here you are getting near episode 100, where we're going to talk about back pain, and we're going to get to something called kyphoplasty, a procedure that you're an expert in doing. Now, let's just review with our audience. An interventional radiologist is a medical doctor who's done both a residency in radiology, reading x-rays as it used to be. We used to have actual films, Kavi. You may not have ever seen it. It's an actual film and actually has a sound to it. And you put it in what's called a light box and look at the film. And then you did a fellowship in interventional radiology. So you went from San Francisco to North Carolina. That must have been a hell of a culture shock or switch for you.
Little change. You know, it's crazy, Gil. At this point, I've been on both coasts, and here I am in the middle of the country.
Yeah.
But I'm excited. You know, I think it's amazing that, you know, you've had interventional radiologists on your show. I'm honored to be your third IR. It's a really cool specialty. And, you know, to your point, it's a very diverse specialty. So we treat a variety of conditions from head to toe using imaging guidance. And the field itself is changing very rapidly. So, you know, I'm actually part of the older training paradigm. It's actually changed a couple of years. I got out of training in 2018.
Okay.
It used to be that you did an intern year, then a diagnostic radiology residency, which is what I did in San Francisco from 2013 through 2017. Then you do an interventional radiology fellowship. Nowadays, there's actually a combined interventional radiology residency. After an intern year, which is generally a surgical year, students will then go on to a full integrated 5-year program. They still do 3 years of diagnostic radiology because it's still very critical to having that imaging foundation. But imaging ultimately serves as a tool for a lot of what we do. But it's just one piece of that puzzle to take care of patients, still a very critical one. So things have changed rapidly.
Yeah, you have to have a lot of skill sets. Yeah, when I decided to become a fertility doctor, reproductive endocrinologist, we do a lot of surgery, and I could tell the surgery was just in its infancy. The minimally invasive surgery, I said, man, there's going to be a lot of improvement here, and it has taken off. So you had a good feel for that. Now, I see it says on your shirt, Image Guided Solutions of Missouri. So is that your private corporation?
That is. We are Image Guided Solutions in Missouri. I'm a solo interventional radiologist. We opened up our practice in November of 2024, so we just celebrated 1 year.
Good for you.
Yeah, thank you. Appreciate it. It's very exciting. We do outpatient interventions, again, a variety of different conditions. But, you know, I think what's cool about IR is, you know, we really focus on a lot of different patients, a lot of different pathologies. And traditionally, we've been hospital-based, and that's still a critical component of what we do. You know, I think we're very lucky where we live. We have a lot of excellent interventional radiologists in hospitals, and they're critical for some of the reasons you mentioned, taking out clots in the brains to treat strokes and dealing with bleeds in the middle of the night. And they still serve a vital function reading diagnostic imaging. But I think what's kind of new and cool in our specialty is actually expanding to a variety of conditions in patients who are not necessarily seen routinely in hospitals. So the cornerstone of our practice is really to improve access to minimally invasive therapies that involve a lot of patients who have a lot of common conditions.
Yeah.
So we do things like vein disease, we focus on arterial disease, we do things like kyphoplasty for back pain that we're going to talk about today, in addition to treating men and women both with their respective conditions that are very frequent, like benign prostatic hypertrophy or BPH, or also dealing with women with uterine fibroids. And
Yes.
a lot of those have infertility.
Yes, they do.
You know very well. And it's really fascinating. If you take these entire cohort of patients with these pathologies I mentioned nationally, that's 50 million patients.
Oh, huge need for you. And as you develop new and fancier things, more and more people will benefit from them. Now, you're an affiliate of the Columbia Orthopedic Group, and we have tapped COG for their talents. We've had their surgeons on talking to us about knees, back, sports medicine. Our most recent podcast was on your shoulder expert,
Yeah.
Kurt Borman. So COG is a very strong group, a great resource for the community. So it's nice to see you integrated with them. So let's talk about just back pain in general. Apparently, it's the leading cause of disability around the world. The numbers are just staggering. At least 80% of people have an episode of back pain sometime in their life, and almost a quarter of adults are walking around with a nagging back pain. A quarter.
Right.
Wow. So you must know a lot about back pain because you want to choose the patients that have the problem that you can help. You don't want to just do this on anybody. It's called patient selection, isn't it?
That's right. And it is a very common issue. And I think most of us, when we get to our 30s and 40s, if you haven't had an instance of back pain, I'd be really jealous.
Just wait. It's coming.
Right. Exactly. So, it's very common. It's a common reason for emergency room visits. It's a common reason to call into your primary care doctor. It's a common reason for medical imaging. Things like x-rays for lumbar pains, very common, lumbar spine x-rays. Things like cervical spine x-rays for neck pain. Also imaging like MRI. Very, very common, with lumbar spine MRIs probably being one of the most commonly ordered examinations. Yeah, and there's a lot of different reasons for back pain. I would probably say for the majority of patients who have back pain, it tends to be more muscular, and we can talk about some of those reasons in more granularity.
I'd like to do that. And back pain is so common, there is a whole specialty of chiropractic, and we've had chiropractor friends here. Can keep them very busy as well. So there's so much pain to go around. It's really just staggering, like I said. Now you mentioned musculoskeletal. That means muscle strains and whatnot. And like I said, most people experience bending over wrong or twisting wrong or picking up something heavy. In the medical field, moving patients is a huge problem because nurses, orderlies hurt their backs all the time moving people. And they've got these contraptions and machines, but a lot of disability in the medical field just from moving patients.
Yeah, that's right. I mean, it's staggering. Thinking about, how frequent and how severe back pain can be. And certainly moving patients is definitely a big thing. I know when we do our procedures, some of our patients, it could be a lot of stress for our nurses, our technologists, even myself when I help out.
Yeah.
It's a lot. And I think, a lot of back pain is mediated by or related to muscular strength, and straining muscles in the back is a big one. And it's pretty common to have aches or pains. Yeah. And I think the hard part for patients, especially those listening here, are trying to distinguish, what's actually back pain related to your muscle versus back pain that's something else.
Yeah, the joints, the bones, the discs, the nerve roots, all these things. I remember reading an article not too long ago. They showed that when two people try to move a patient, it doesn't help because it's an awkward position for both.
Right.
So you got to have these cranes and things, these moving devices. Now, maybe to people's surprise, it turns out a lot of muscular pain, chronic back pain, is due to stress and internalizing and holding this pain, this tightness as a fear response, as a guarding, as a protective mechanism. And you get the x-ray, in the old days you get a plain x-ray and say, Mrs. Smith, there's Mr. Smith, there's no obvious bony abnormality. Now, people don't want to hear that it's in your head. And I'm not saying all back pain is, but a significant chunk of back pain is in fact just a fear response and a tightening, a guarding, we call it.
Definitely. I think it's one of the most unsatisfactory examples for patients where it's like, man, my back is hurting so much. And that x-ray is negative, or that MRI is negative, or that CT is negative. But that goes to show that oftentimes it is the muscles. And to your point, it is protective. There's a lot of muscle spasm that happens. The muscles tighten. And sometimes that could be induced by things like trying to move patients in awkward positions. Simple things like bending over. And I think a lot of it has to do with our core strengths and strengthening our core and making sure that we're positioning ourselves properly to kind of help protect our spine. And I think when we find ourselves in awkward positions doing things and maybe overexerting ourselves, it's very common to kind of have that pain. Yeah,
I experience that personally. The surgeries I do, I'm getting better in my mid-60s here at realizing I'm in a bad position, but sometimes you're in a bad position to do what you have to do. Just in general, I've gone down some Instagram rabbit holes, and I have found some tremendous resources. I can't name them right here, but there are experts in Tai Chi showing wonderful exercises and movements for the back. I've seen Alexander technique, Feldenkrais technicians, physical therapists. I've had just some tremendous exercises and regimens for back rehab and core strengthening on the internet. Now, I'm not going to say which one's good or bad. I can't tell you that right now. But there are some fantastic references and resources out there from people sharing all these different movements and whatnot. Now, in my personal world, I have a good friend, chiropractor, Dr. Maxwell, works on me. I have a massage therapist that works on me. I go to the gym, and in my case, I've been able to work up to squats, and just doing squats has tremendously increased my back strength and has helped my back pain quite a bit. Now, you also have physical therapists at Columbia Orthopedic Group, so you've got a plethora of resources for people to use once you've ruled out, a disc or a nerve problem.
Exactly, and that's the beautiful thing of practicing in a multidisciplinary setting. Is back pain is very diverse. And as a physician, I'll tell you, back pain is hard. It is hard to actually work up back pain. And it's challenging. It's challenging to meet patients where they are, too, because it hurts so much.
Yeah, they come limping in, and they're taking off time from work, or they're taking relaxers, or, God forbid, they've become dependent on opiates.
Right. And back pain, unfortunately, has led to a lot of that use historically.
Yeah.
And I think one of the great things that, I think we do collectively at COG, Columbia Orthopedic Group, in our community here is we do have multidisciplinary experts. So we do have physical therapists that we collaborate with. We also have a wonderful group of pain management specialists who we work with who spend all day dealing with back pain.
I'm friends with some of them, yeah.
Yes. So, they have a tough job, but they're experts because they oftentimes are generally some of the first people who see these patients, also in conjunction with our spine surgeons.
Yes.
Yeah. So.
Yeah, and I can tell you, your spine surgeons are busy, and they do not want to operate on somebody they cannot help. They better have something they want to go for, because that's a nightmare. Yeah, and they're so busy they can pick and choose and do just the cases that they think they can help.
Exactly.
It's very important because in in any field of medicine, if there's a doctor who's not as busy as they want to be, they might start taking on cases that are questionable.
Right.
Exactly. You see that with every specialty.
100%. And I think the nice thing is being in a team setting, we are able to help each other and work together, which I think ultimately that benefits patients.
Absolutely.
They get streamlined care, and I think they get very straight answers of what's going to help and what's not going to help. So it's nice to tackle together because when you're on an island by yourself, it's a lot more challenging.
And we take an oath to first do no harm.
That's right.
And that is true 2,000 years later. So obviously if there's a sudden trauma, a car wreck or you bend over, kind of when the event happened. So let's say somebody has a traumatic injury and they're middle age. How does Kavi initiate a workup? What are the things that you're going to do to evaluate this person to find out what is the cause of their back pain?
Sure. Generally in our practice, since we are outpatient-based, we're oftentimes not seeing patients who immediately present at the scene of a car wreck and go to the hospital. But oftentimes we're seeing patients who maybe have had an injury at some point, and maybe they were good enough to make it home and not end up in the hospital. And they might come in for back pain. And if I were somebody who maybe found me online or decided to direct an appointment directly with my clinic, I'll see them in clinic first. That's the first thing we do. So very simple history and physical examination. We spend time with our patients to actually hear their stories because that's probably the most important thing.
That is music to my ears, Kavi. You got to take a good – in medical school, they'll tell you 80% of your diagnoses are from the history, just talking to the patient.
Exactly.
Which takes some time and some sensitivity.
It does take time, sensitivity, emotional intelligence, all of that.
Yes.
And, it's funny because oftentimes patients know what's wrong with them.
I'll tell you.
That's something that I've learned. So, it's kind of
Listen
funny.
to the patient.
Right. The patient will tell you what's going on. So, invariably what we do then is we do a physical exam. And our physical exam is usually very limited and very simple. We like to palpate. We like to feel the spine. We like to see what it's like when the patient flexes, when they extend back, when they bend side to side. I like to see them touch their toes. I like to see them walk. So I'm paying attention as they're walking from the waiting room to my office.
The gate. How do they come in the door?
That's right. So you get a really good sense from the moment you see a patient exactly, how severe this issue is, what their functional limitations are, and the impact on their quality of life. Those are all very critical. For me, then, what I'm thinking is there a pain generator specifically in the spine? And for our listeners, what I mean by that is there something in the spine that's actually causing this pain? And there are a few things that can do it. And, really what's going through my head is it the bone? Is the bone broken? The vertebral body? Is it what we call a degenerative change? Are the discs between the vertebral bodies broken? And we could point some of these out.
So here's a little model. Here's a fancy model here. But these are the vertebral bodies. These are sections of bone. Mm-hmm. And between them are these cushions, these spongy, these springy cartilage things called discs, I believe. Mm-hmm. And then there's these areas outside between them where the nerves come through.
That's right.
So you're looking for pain generators. Where do you see pathology or something abnormal? Am I right?
That's right. Exactly. So, what could go wrong with the spine, right? A few things depending on where it is. So what we'll talk about later in today's episode are if the bone breaks. So if the actual bone, the vertebral body breaks, and that's a vertebral fracture. We'll talk about that. That is very painful, without a doubt. Oftentimes that's pain that's actually felt in that location. So, of course, our viewers know that when we're actually looking at a patient, we can't see this. I wish I had X-ray vision, but I don't. So what we're actually doing is we're actually palpating or touching the spine or pressing. And oftentimes with broken bones, if you actually press on that area, it will hurt a patient a lot. They'll say, ouch.
Ouch. And you go away and you come back, ouch again. It's repetitive, consistent.
Exactly.
Focal.
That's right. And what patients will tell you, they'll say, this is the kind of pain that takes my breath away.
Oh. A true 8 out of 10
That's
or
right.
more. Yeah.
Exactly. So that's very severe pain that's usually felt, especially during transitions. So from sitting to standing or standing to laying down in bed, those transitions are very, very painful. And patients will say, it feels best when I'm just not doing anything. So that raises my suspicion if there's a fracture. But as we talked about, there's other reasons for back pain. The discs, as you mentioned, in between, those could degenerate over time. Those are like shock absorbers. And when that happens, bones could rub on the bones, and that could create pain. That's disc-related pain. Generally, that manifests differently. That could be more dull, a little bit more achy. Worse when you've potentially been on your feet for a while, you've been active. And as degeneration progresses, the bones that articulate with each other between the spine, the different levels of the vertebral body, these are the facet joints, they can wear down too. And when bones wear down, they actually grow and they become hypertrophied.
Oh.
Yes.
So are those little spurs and calcifications?
Exactly.
Oh.
And those those are bad. Those could pinch off all these little nerve endings that come off, and that can cause something called radicular pain.
Radicular meaning root.
Exactly.
Radical is a root.
That's right. And what's wild about this, Gil, is these actors work in conjunction with each other. So you can have facets that are degenerated, but you could also have discs that can actually creep back to the back where the spinal canal is, and they could pinch nerves, and they could actually pinch the spinal cord.
Oh, that sounds horrible.
Yeah, very bad. So these things could happen, especially with disc-related pain, that could happen after trauma as well. But generally for most patients, these types of pain, these types of mediators worsen as we age.
Yeah, unfortunately, yeah.
Unfortunately, they degenerate. And then you can get a lot of degenerative-related pain, be it either not just pain in the back, but also pain in your legs potentially if the nerve roots are affected.
Gotcha. So is that kind of inevitable, back degeneration with age? We just try to bend the curve, try to hold out as long as we can.
It is for most.
Sorry.
Anyone who lives long enough is going to have something going on back there. So I think the cool part of my practice is I get to see a lot of patients in their 80s and 90s. And in fact, even a few patients are older. And yes, over time, you will see that in patients.
Now, what is a herniated disc or a bulging disc? Can you explain that to me?
Absolutely. So that actual space between these two vertebral bodies, I could also show it here.
Sure.
That space, what happens is that's a shock absorber. And that shock absorber could actually creep out into the back where the spinal cord is or the spinal nerve roots are.
Okay.
And that material from that disc can actually pinch off those nerve roots.
So it's a hernia or a bulge.
That's right.
So the annulus, the ring, has a defect, has a weak spot, and it can actually
That's right.
go out through the weak spot.
Yep. It can go out through the weak spot and it could wreak havoc.
Now, is there anything that you do for that, or is that more the spine surgeon realm where they put in artificial discs and
That's a good question.
fusions?
Most of those patients are usually managed by either spine surgeons or pain management doctors. There are interventional radiologists across the country who do see those patients as well, and we have some of those in our practice. But we collaborate with our friends in both surgery and pain management, and there are solutions that are both surgical and solutions that are non-surgical or more image-guided. And a lot of the tailored solutions really depend. They depend on a patient and how old they are. They depend on how sick they are and whether or not ultimately they may or may not be a good surgical candidate, because certainly no surgeon wants to operate on some patient who might be at a higher risk.
Sure, you got to weigh the risks and the benefits, don't you?
Exactly.
What is sciatica?
Yeah. Sciatica is a commonly used term, but generally what that's referring to pinching a nerve that basically goes down our leg. And
the back of the leg usually, right?
The back of the leg, the sciatic nerve, so they call it sciatica. And generally it's pain that's in the buttocks that kind of radiates down the back of the leg. It's something called a radiculopathy.
So the sciatic nerve has big, thick roots. They're some of the biggest roots in the body.
That's right.
Easily pinched by various things. in the spine. Or in my world, you can have deep endometriosis on those nerve roots. Very difficult surgery to perform.
Yeah, absolutely.
To get that impingement off of there.
Yeah, that's it's a hard condition, definitely. Most patients with sciatica actually get better over time. So,
that's good to know.
Maneuvers, physical therapy, and time will take care of the majority of patients. Some patients may not get better with conservative management. And for those patients, that's where surgery, such as spinal decompression, actually removing some of that disc material and creating space in the spine, that could help. Or non-interventional options, such as doing targeted epidural steroid injections to actually reduce the inflammation through tiny needles that we can insert into that epidural space. Those are options for many patients as well.
Reduces swelling, can help with pain, avoids a big surgery.
Exactly.
Interesting. So let's move on to things that exacerbate these back issues or make them worse. There's aging, apparently around age 30.
Yeah.
That's kind of a cutoff. Yeah. Also, poor posture, is that a problem?
Poor posture.
As I sit up straighter.
Yeah, exactly. Guilty of that here too. Poor posture is definitely a big consideration for sure. So
we can actively work on that. And that's where a physical therapist, chiropractor might help you with that. So, lack of exercise. As I've gotten older, I use the elevator more often. I try to force myself to climb the stairs when I can. Do you have any just general recommendations for a baseline? Now, we've also talked about exercise and muscle strength in the context of longevity. We're about to release a podcast. We just did an interview with Dr. Chris Link on longevity and muscle strength and whatnot that came up for longevity. But do you have any basic recommendations for exercise for someone who's not a gym rat or a runner or something that would be a good kind of maintenance strategy to keep your back strong without necessarily having to get a gym membership or hire a trainer?
Absolutely. So I think a simple thing that most people can do is they can do exercises at home. And oftentimes we talk about this with our patients. And to tell you about interventional radiology and how far it's advanced, who would have ever expected a radiologist to tell patients about strengthening their core?
Right.
Do it all the time. So core strengthening is critical. I think the more we can work on our core, the more we can actually protect our spine. So I encourage everyone to just spend 5 minutes a day. That's it. Nothing crazy. Just pick 5 minutes and work on simple core strengthening exercises, things like sit-ups, things like planks. I think it's also very important to stretch. So strengthening our hamstrings, our quads, those are all very, very important, help improve flexibility. I think those simple exercises can actually go a long way. It doesn't have to be anything too elaborate.
Yeah.
I don't tell patients to train as if they're looking to develop a six-pack. Really trying to just do simple things to strengthen the core. And I think that goes a long way over time.
Yeah. And like I said, lots of good resources on social media and in the internet to help with that. Now, obesity. I've struggled with obesity myself for many years. It's a huge cause of infertility. We have a large percentage of our patients struggle with their weight. And weight is not good for the spine, especially the lower back, is it?
No, fortunately not. If you think about our spine is, the main pillar of our bodies, right? It's supporting a lot of weight. And when you think about our lower spine, our lumbar spine, it's kind of the bottom of it, right? So you could think how weight can really affect that spine, and it can help accelerate some of these things like we talked about, like degeneration, low back pain. Weight can make it harder to actually maintain good posture. So those are all factors that influence back pain.
All right, so that is a deep rabbit hole. We're not going to go down there.
Yeah.
I have had some episodes on that as well. And I believe even smoking can contribute to back pain.
It absolutely can. I can't think of many things that smoking is good for.
Maybe looking cool in a black and white movie.
Yeah, maybe that, right? Yes. So definitely. And smoking also is very bad for not just our vascular health. As a vascular interventional radiologist, we're dealing with blood vessels all day. So we're having these conversations with our patients. But smoking is also a negative factor when it comes to our bones and how strong they could be. So bone health is very much a factor that can influence back pain and can accelerate the weakening of bones.
Now, there's some other things I just want to touch on real briefly. You can have back pain from something else. You can have a kidney stone, like I mentioned, endometriosis in usually younger women. You can have an infection. You can even have a tumor in your back. And the first thing it shows is pain. So when you see a patient and you've palpated them and you've done your history and all that kind of stuff, what would be your usual image in the old days? And I know my chiropractor friends still do an X-ray.
Yeah.
You can get a lot of information from a plain old X-ray. What kind of imaging studies would you use, Kavi? Obviously, MRI is the fancy, but it's really expensive.
It is, yeah.
When do you use an X-ray?
Yeah, so it's a great question. And, as much as I, joke about X-ray being old school technology, still very critical. And for us, that's the first line imaging test for pretty much all of our patients. So we will start with generally a lumbar spine X-ray. That's the lower part of the spine. And we'll see if there's any obvious pathology. Now, there could be X-rays that could be seemingly negative. They look like they're normal. You can still have pathology there that you can't see necessarily. So this is when we actually take the patient history, our physical exam, and combine it with our imaging to see if that X-ray makes sense or not. And if that X-ray doesn't make sense, that's when we move on to advanced imaging, such as CT or MRI. Which
CAT scan is an X-ray, essentially cuts the body into little tiny slices. MRI, magnetic resonance, that's the fancy one. You go in the tube that goes, it can be terrifying in there. But that gives you your best images, the MRI. Is that true?
It does. So MRIs really show us a lot of detail. They show us a lot about the spine that we can't necessarily see with an X-ray or a CT.
It shows soft tissue as well, right? Not just the bone. Am I correct?
That's correct. We can see the nerve roots. We can see the discs. And even within the bones themselves, we can see pathology in the bones that may not be visible on an X-ray. So, for instance, you can have a break in your bone and the X-ray might look normal. It's possible.
So, you've ruled out the tumor, the infection, the kidney stone. Now let's start going more into your wheelhouse, Kavi. As we get older, and particularly women after menopause, estrogen falls, reproductive hormones fall, and guys, testosterone's going to fall, and the bones can get weaker. It goes into weak bones called osteopenia, and then when it gets to a certain threshold, it's a statistical number, call it T-score. When it reaches a certain point, then we can call it osteoporosis. The bone starts getting very weak, doesn't it?
It does. And osteoporosis is a silent killer. It is a very common condition. And the way I explain it to patients is if you imagine a beam of wood, such as a beam that will support a house, you could think about how solid that is and how firm it is. Think of osteoporosis as that beam turning into a sponge.
Termites.
That's right. You got termites creating little holes and pores inside that wood, and that bone starts to weaken, and then it could break. And that's osteoporosis.
Yeah, and it can happen anywhere, and it's no laughing matter. Usually it's a woman, elderly woman, falls, breaks her hip. I think the chance of her being dead within a year is very high because not only are you immobilized, now you get pneumonia, infections, bed sores, just general degeneration. It really, you fall off a cliff when you have such a catastrophic injury.
Absolutely. And anyone in my line of work who's been in a hospital before has sadly seen that happen.
Yeah.
And osteoporosis, there's a significantly higher mortality associated with patients who have osteoporosis.
Yeah.
It is very common. It's over 20% of women over the age of 50, upwards of 50% or more by the time they're 70.
Yeah.
And not to exclude men as well,
Right.
but closer to 10% of men over the age of 50. And that, of course, increases with age.
Yeah. Yeah. Yeah, men start out generally with higher bone mass to begin with.
That's right.
Testosterone doesn't fall off a cliff at age 50 like estrogen falls off in women. And it is equal opportunity destroyer. Now, my grandmother liked to travel in her later years. And I remember as a kid, I don't know how, it was many decades ago, I remember she went to Africa and flew in a little bush plane, Tanzania or Kenya, wherever she was.
That sounds great.
Yeah, I hope I have time to do that when I get older. But she was in a little plane, and it had a hard landing. And I remember she came back from that trip in severe pain, probably about an inch shorter. And what had happened is she had osteoporosis, and she had compressed and broken her vertebrae in this hard landing. And they did not have kyphoplasty back then. So let's say you have I assume that the majority of your patients are probably older women. They have osteoporosis perhaps, or they have weak bones, and they have a trauma. And they've got severe pain, and you can probably tell from the history, Kavi's already suspecting that we have a vertebral body compression fracture. How do you go about determining if that's the case?
It's really fascinating, Gil, because I'll tell you, oftentimes you can tell the moment you walk in a room.
Yep. Hard landing, 70-year-old woman. There you got an inch shorter now. Yeah.
Exactly.
Yeah.
And it's funny because in our clinic rooms, we usually have an exam table and we have a little chair. And for most of our patients are sitting in the main examination chair, and their family or whoever's with them is sitting in the normal chair. And oftentimes I can tell from when I walk in and I see the patient is not getting up on the examination chair. It's too much work. It hurts too much. So that's usually how I can tell, because that tells me how bad this pain is, number one, and how hard it is to move, right? It'll be very, very apparent generally. So usually patients describe it as terrible pain with movement. So usually you can tell just from looking at a patient, they'll have a hard time getting comfortable. There's almost no position other than maybe laying flat and not doing anything that would make them feel as comfortable as they can be. Then, of course, our physical exam maneuvers and actually feeling the back of the spine and pressing and the area that's broken. When we press, we can actually elicit pain. So a patient will say, ouch.
Ouch.
It really hurts. That's usually the first thing. And then, of course, we move on to imaging, as we talked about.
What do you do?
So we usually start with an X-ray. And what we're looking for on an X-ray is we're looking to see if the actual bone itself is actually compressed. And it'll look something like this, where if
you can see that.
You can see it. It looks like a wedge. It's broken. It looks like a little wedge there.
Sometimes little pieces of bone will actually be kind of snapped off and it's satelliting around.
It can, depending on how bad the trauma is. Sometimes you can have part of the bone that pokes to the back where the nerve roots are, where the spinal cord is. So I would say for the majority of patients, who have osteoporotic fractures, usually you'll see a wedge, a little collapse. But the thing that's a little frightening that we have to keep in mind is you can have a break in your bone related to osteoporosis, and you may not see that wedge. Oftentimes, by the time you see something on an X-ray, that fracture may have already been there for a few weeks. So I would say a lot of our patients being in the outpatient setting, we usually see patients generally at least a few weeks after they may have had an event. They may not come in right away. And the scary part about osteoporosis is actually more than half of fractures in the spine are silent. So patients could have it and not even know about it. That's the thing. So we're oftentimes seeing a subset of patients who generally have a degree of collapse that is so painful it's causing them to come in.
It's called a selection bias. You just see the bad ones usually.
Absolutely.
Yeah.
And we're just seeing a subset of those because for some patients it's so bad they'll go to the emergency room. They may end up hospitalized. And that's where our friends and colleagues who are doing interventional radiology in a hospital will play an important role diagnosing and treating those patients.
So you have diagnosed a vertebral compression fracture in our patient. Like I mentioned, my grandma, all they had were pain pills and maybe some steroid injections. But you now have an advancing technology that actually repairs this. Now, I believe back in the late 80s, there was something called vertebroplasty, where I think somebody had the bright idea that maybe you could inject some cement in there and at least kind of fix improve things a little bit. Is that the case back in the old days?
That's right. So it used to be that, and it still is today, that many patients were treated by actually taking a skinny little needle. And what we do is we put it through the back here. So there's something called a pedicle. These are the main parts of the bone where we can actually safely insert a needle through the bone. So we're avoiding any nerve roots. We're actually getting into the vertebral body. And then we can carefully inject medical grade cement that'll get into that fracture and then solidify. Mm-hmm. And the reason that's so important is because what causes pain in these patients with fractures are actually the movement of the bones on top of each other. That movement and that rubbing could be very, very painful. So by actually having a construct, by having this cement, this medical grade cement that creeps into that area and solidifies, we then prevent that movement. And what ends up happening is that results in less pain when patients are actually ambulating and moving around.
Do you still do that from time to time?
We do. We definitely do that time to time. I think a lot of what we do is dependent on patient selection in terms of age and the morphology of their fracture. That's a fancy way of saying what the fracture looks like on imaging, right? Is there actual height loss? Did that vertebral body collapse? Or is the height still maintained and is there just a little fracture line in there? Now, certain patients, and I'd say the majority of our patients, we're performing not a vertebroplasty, but something called a kyphoplasty.
Yes, I want to get to that. But before we do so, how do you know your needle's in the right place?
Excellent question.
Doctor of radiology.
We are nothing without our imaging tools. So we use live x-ray. It's called fluoroscopy. And yes, what we do is we're basically continuously and intermittently, depending on the portion of the procedure, we are imaging the spine as we're carefully advancing our needles into that vertebral body.
So you're watching where you're going almost real time.
Exactly. Okay. Exactly. And when we inject the cement into the bone, we are watching under real time.
You're going and you're actually watching it go in, make sure you're in the right place.
That's right.
I imagine cement in the wrong place could be a disaster.
It could be a disaster, but the nice part about what we do is it's actually very, very low risk. Complication rates far less than 1%.
That's great to know. And once again, this is in experienced, trained hands like you.
That's correct. So the great thing in our community is we have we have interventional radiologists here who are very skilled, very talented. So I know, oftentimes patients should feel comfortable in the hands of interventional radiologists. But this is a multidisciplinary sport, as I say.
Yeah.
So we have other physicians, too, who perform these procedures safely at a high level, including orthopedic surgeons, spine surgeons who may be neurosurgery trained, pain management physicians. All of us collaborate together on these patients. I just happen to be an interventional radiologist, but the one thing that kind of brings all of our specialties together when it comes to this procedure is the imaging guidance and being an expert at the imaging to make sure that we can do this safely and effectively, to make sure that cement goes where we want it to go and not elsewhere.
Now, the cement, you have to push it under some pressure. It can leak and whatnot. So I believe in the mid to late 90s, I think it was an orthopedic surgeon came up with this idea, well, maybe we can expand this space with maybe a balloon. And there was a company called Kavi, established 1994, was FDA approved in 1998. And I assume this is a type of procedure that we're going to be getting to. This is the kyphoplasty?
That's correct.
Tell us about it. I'm all ears.
Yes. So unlike a vertebroplasty, which is just injecting cement and not actually creating space inside the bone, kyphoplasty refers to something called cavity creation. And, the traditional description is, as you discussed, is using a balloon to actually make that space. The idea is that if you have a fracture, especially one that has lost some height, then what we could do is we can actually insert either 1 or 2 needles, depending on the patient and how we choose to approach it with their anatomy. And we can put in these balloons that'll take this vertebral body, send it from being compressed to normal height.
It'll puff it right up. I'm thinking of the commercials I see on TV for cement. There's these people will come and they'll fix your deck or your walkway or your foundation. They'll put foam in there and zzz, up it comes.
That's right.
It re-expands it.
That's right. You could think of this as the medical version of that. So
foundation repair doctor.
That's right. So it's a cool procedure because, that balloon is nice. It's very nice to create space, and that space helps restore height. And height restoration is critical because what happens in patients, even in patients with silent fractures over time, is when that vertebral body height is collapsed, that puts stress on the levels above and below it, and it could more or less screw up one's balance, and that can cause chronic pain over time. So by being able to restore as much height as possible, we can basically try to get a patient back to their normal biomechanics to help prevent more aches and pains over time.
Wow. So the pressure is being exerted by the balloon, not the cement. You make a cavity in there. So you're re-expanding, and tell me if I'm explaining this correctly. So you're re-expanding through the vertebra till it's close to normal size, and now you have a cavity in there. Then what do you do?
That's when we put in the cement to fill up the cavity. That's it. And the nice thing about creating a cavity as well is it's actually a very safe procedure because creating the cavity creates a space to put that cement. So then we actually worry a little less about cement leaking outside of the bone.
You're not having to push it in under pressure. It just goes in smoothly.
That's correct. We're creating an area of lower resistance. So that cement could nicely flow into that area. And the interesting thing about the cement that we use for these procedures is they harden over the course of 15 minutes or so. So if we need the cement to be a little thicker, we just wait a little bit, right? Or if we need the cement to kind of diffuse into an area a little further away from where the axis is, we might inject it a little sooner.
Well, it's thinner.
Exactly. So
that makes a lot of sense.
Yeah.
And you do it in the office. Now, is the patient asleep for this or sedated or fully awake? Does it hurt a lot?
Excellent question. So I would say that, pretty much everything that we do in our office, it's outpatient, and we're doing it generally with something called moderate sedation. So I'm sure a lot of our audience, may have had a colonoscopy of some sort. And that's generally a slightly deeper version of sedation where you might get a medicine like propofol that'll, kind of give you a nice nap and 15 minutes
asleep and it's over.
It's over. This is not quite that, but it's close. What we're doing is we're giving a pain medicine and an anti-anxiety medicine through an IV to get you in what I call the twilight zone.
Okay.
So it's kind of that state when you're first waking up in the morning or when you're about to go to sleep at night. You're not quite there, but you still might hear things in the background. And that's generally the level at which we get patients. And we do that for a reason. One big thing is safety profile. We obviously want our patients to feel comfortable. But a lot of our patients who may be older may have other medical conditions as well. And it might be actually safer, it is safer to do it this way instead of giving them deeper sedation or general anesthesia, which actually could place stress on our heart and lungs and could potentially tip the risk-benefit profile of what we do.
So you twilight them, and do you ever use some local anesthesia too?
Absolutely.
So you're injecting some lidocaine or bupivacaine or whatever cane you du jour.
We love our canes.
Love our canes.
So we got lidocaine for the skin, and then we give some bupivacaine using a skinny needle right on the back of the bone where we put our needle through. And what we do to limit pain for our patients is I'd probably say the vast majority of our cases, about 80%, we generally only put one needle into the spine. And we can direct that needle across so we can affect both ends or both sides of the spinal vertebral body without having to put in two needles. I'd say for most patients, this is generally pretty well tolerated. Mm-hmm. The parts where they tend to feel are when we gently tap that needle into the bone. That part can cause a little pain, but usually nothing that isn't tolerated. Most patients have more pain just moving around with their compression fractures.
That's keep going, doc. That's nothing. I've been living with this.
Exactly.
Yeah.
Yeah. So it's pretty well tolerated. I'd say when we're done with the procedure, oftentimes patients are feeling a lot better. It's actually one of the most satisfying procedures that we do because the pain relief for many patients is almost instant.
Wow, that is fantastic. Now, the cement, have there been any advancements in the type of cement? I know most bone cements are hard and very hard.
Right.
Have they come up with some softer, spongier cements?
There have been some advancements. So there are cements now that, it still is fairly hard, but the advancements are often related to how we inject it and our ability to control it.
Okay.
So there's different viscosities, so different thickness now. Some of them will harden a little sooner than others. So that allows us then to maybe get cement in a little quicker and maybe, decrease our table time for the procedures. And there are new cements that are not quite yet on the market, but that will be coming out soon that will actually perhaps allow us to more safely instill it. And that's not to confuse listeners and say this isn't safe. It's still very safe, but provide us even more confidence in actually making sure that we get everything where we want to get in. Because I think one of the biggest things that I tell patients over time is when we see them in the office and I remind them at follow-up visits is having cement in your vertebral body is kind of like having money in your bank, right? You really shouldn't complain about having too much of it.
How do you know how much to put in?
That's a good question. So we're oftentimes basing that answer on the imaging itself.
You can watch it fill up and say the tank we're on full.
That's right. And as we inject that cement, the cement itself can help raise the height of the vertebral body. So we want to get a sufficient volume of cement. So if we're looking at a patient out on front via our x-ray, we're getting enough that's covering side to side. And if we take a 90-degree image where we're taking a look at a patient from their side, we want to make sure we're getting enough cement that's going from the front to the back.
So this is where doing hundreds and hundreds of these over years and your experience is priceless.
It's critical.
Critical.
Absolutely.
Do you see any other advances coming?
Yes.
In this, where do you see this going?
So I'm happy you brought that up because we've been talking about as a broad category, something called vertebral augmentation.
Okay.
And vertebral augmentation is just a fancy way of saying we're basically changing the vertebral body by injecting or putting something in the bone. And traditionally, this has been cement. There's vertebroplasty, like we mentioned, which is just putting cement in. Kyphoplasty, which is cavity creation, generally putting balloons in or using a device to just scrape bone and make space in it. And there's a third category, something called mechanical augmentation. And that's actually where we can implant some kind of construct or device to actually lift the bone up, to actually give it a scaffold. So there's something inside of it that's actually pushing it. And there's a tool out there that's kind of like a car jack, and it's called a spine jack, for instance.
I love it.
Yes. So we can actually, through two tiny needles, insert this device where on the outside of the patient, we can crank it up, and you could actually in real time see the vertebral body come up. And then when you're done, you just put some cement around it to keep everything solidified. And that's a relatively newer advance within the last 5 to 10 years.
And it stays in there.
It stays in there.
Now, what keeps it from getting infected other than obviously, keeping things sterile and cleaning the skin? But a foreign body, if there's like one bacteria on there, it can hide from the immune system to create an abscess or something.
It's a really good question. And what the data has shown us is the infection rates are exceedingly low. They're very rare. So
it's good to know.
Yeah, patients should rest assured that these are procedures that are associated with very, very low infection rates. So I think simple things, of course, like sterile technique is very important. But I also think that making sure we're doing these in appropriate patients, so we're looking for active infections, and we're trying to make sure that we've cleared out infections before we implant devices like these. That goes a long ways in kind of preventing any, bad complication resulting in that.
Gotcha. During my reading, I heard they used to put tobramycin antibiotic in the cement, and it just didn't make any difference.
Yeah, and it really hasn't. So, for those of us doing these in a high volume, and we do some mechanical augmentation in our office as well, we typically don't use any antibiotics beyond the standard peri-procedural antibiotics.
You give some in the vein?
We do.
A prophylactic antibiotic?
Absolutely.
And we do that for a lot of different surgeries. It's during the vein, during the procedure, and that's all you need.
Exactly. And that tends to be perfect. I think the hard part is if we have patients who have bad infections, and osteoporosis actually can be associated with bad infections. So a common one is actually pneumonia. So for patients who break, especially their thoracic spine, but this also happens anywhere in the spine that you may break a bone, limited mobility, limited ability to take in a deep breath, for instance. Patients are at a higher risk of having pneumonias. So, generally speaking, that won't necessarily stop us from doing a procedure, but we're a little bit more cognizant. It's a tough situation because if you don't treat the patient's spinal fracture,
they can't breathe.
Exactly.
As was widely.
Exactly.
Openly.
I'd say the mechanical devices currently for us and in our practice, which is probably like a lot of folks like myself around the country, we tend to reserve the mechanical devices for our patients who have what we call junctional level fractures. So that's the portions of the spine where it's a junction between different parts of the spine. So the lumbar spine and the thoracic spine. Those fractures in the junction, in patients especially who may have maybe very physically active, who may have had a fracture from a trauma, oftentimes these procedures we can actually avoid an open surgery by using mechanical augmentation. We tend not to use these mechanical devices as frequently in our patients who are, I would say, more standard osteoporosis-related fracture patients who tend to have smaller pedicles, maybe vertebral bodies that are not quite as collapsed when they present to us, because these are pretty big devices that we put in. So for those patients, we try to be a little bit more atraumatic in our approach, less traumatic, try to do the least amount possible to achieve the best result possible.
Gotcha. No, I read something about the speed at getting to this. Don't you want to do these, like if there's an event and that's when the fracture compression occurred, is there some benefit to doing this sooner than later?
Absolutely there is, and I'm so glad you brought that up. That is probably one of the hardest things that I face as being a physician in the outpatient realm doing this is we're oftentimes not seeing patients for weeks after they've broken their fracture.
Yeah.
And some of it has to do with, certainly patient awareness, and it's wonderful that we could have this forum to increase awareness. But a lot of it is just to the nature of osteoporosis because of the fact that over half of fractures can be silent fractures. You may not know, or you may not view your pain in your back as being all that severe until maybe later, right? You might have some nagging pain back there. You get an x-ray, you notice something's collapsed. So it's not unusual for us to see patients weeks to months after they've actually broken their bone. And we can still make a critical difference in those patients, certainly. But the hard part is the longer a patient has gone with their vertebral body collapse, the more stress there is on the levels above and below that bone that create other pain generators for the patient, like we talked about earlier, the articulations between the two bones above and below will get degenerated. The muscles alongside those bones will spasm and tighten up harder, and it'll take longer for those muscles to relax. The discs will get degenerated, and that causes problems for patients because we can do this procedure and improve a certain type of pain, certainly. We can take away that really sharp, what we call mechanical pain, where if you try moving, you get that sharp pain. We can make that better. But then patients might be left with perhaps a duller, achier pain that might be related to one of these other reasons we mentioned. So that's where a multidisciplinary approach is necessary, because we want to try to restore function as much as possible for these patients. Now you have to, compare this scenario with the patient who might have an inciting event, like let's say they, broke their bone and they knew it right away. And with osteoporosis, even the most simplest things that you wouldn't think about can cause it. You were talking about trip to Africa earlier.
Right. It's a plane landing. Yep.
That's right. I've had patients who've sneezed, patients who've coughed, patients who so much turn their head to look at their dog, all sorts of things, and then they're in terrible pain.
I sneezed wrong.
Exactly. So let's say that happens, and then, they come in, and we get plugged into our clinic, and, we go through our motions, and we find that there's a fracture. And oftentimes these patients may have presented a week, 2 weeks, 3 weeks from their event, and we get an MRI, and, we do our procedure. Those are the patients that I feel tend to have a higher satisfaction overall, because we have fixed the problem, we have restored alignment, and we've decreased the likelihood of them having pain over time.
Well, that's a great wrap-up summary, Kavi, of this amazing technology, kyphoplasty, and what you can accomplish in improving and changing people's lives so rapidly. That's just wonderful. Now, as we wrap this up, are there other things that you do with the spine, or things that you think are just coming over the horizon soon? Is there anything else you'd like to talk about?
Sure. I think, a couple things. I think one, maybe not quite as, sexy, I'd say, as doing
so that's the word I was going to use.
As fancy procedures. But I think doing this over time, and it's my 8th year now in practice doing this, I've come to realize that osteoporosis is, I think, under-recognized and underappreciated by just about everyone.
Yeah.
And it is a silent killer. And I think if there's one message I want to get across to patients listening to this, is I want them to be cognizant of it. The statistics are what they are, and it's 20% of women over the age of 50 and 10% over the age of 50 of men, and that increases over time. So I definitely encourage patients to get plugged in with their primary doctors, to have tests like bone density examinations to look for the severity of osteoporosis, because at the end of the day, what I do is fun. It's fascinating. I joke with patients and I say it feels like I'm playing video games for a living.
Yeah.
Obviously high stakes video games.
Sure.
But what I do is easy, relatively speaking. Addressing the underlying osteoporosis is critical. Patients with fragility fractures in the spine, they're at a significant risk, upwards of 25% a year, of breaking another bone. Right? And managing the osteoporosis and actually getting patients the right treatment to strengthen their bones is very, very critical. I think when it comes to the spine, there are some very fascinating technologies that are coming out. There's some new technologies coming out related to actually restoring discs to help with degeneration. There's new technology that has come out to actually destroy nerve roots within the spine itself, something called the basivertebral nerve. There are ablation procedures that we can actually use to heat those nerves and alleviate pain. That's a relatively new technology. There's new mechanical devices coming out for treatment of compression fractures. There's new devices where we could insert almost like a string of beads inside the spine to actually fill that space. And it's a little bit different from the standard free-flowing cement that hardens. So all sorts of cool technologies. And the fascinating thing about what I do in interventional radiology is this technology is always changing. The way I treat patients now is different from when I learned this about a decade ago, which is going to be different 10 years from now. So we always have to learn and adapt, which is pretty cool.
Very exciting time to be in medicine. Well, Kavi, I have learned so much today. I really appreciate the time you've given to us. What a pleasure talking to you. And I want to thank you very much for coming on the Dr. Gill Show.
I appreciate it. It's my pleasure to be here and glad we can do it.